It's not.
Just click first on the image. Just click once on the image, and you can use the button up and down.
How to remove the magnification? This is doing magnification. Can you scroll for me, sir?
Okay. Okay, I will scroll for you. You know, another method is there is a toolbar. I don't know because my screen is not projected on yours. There is a toolbar on top, and you can actually drag it. In any case, let me do it for you. Now, so I've gone to the lungs and I'm coming down. Just concentrate on bowel and don't concentrate on anything else.
I can see there is thickening, diffuse wall, diffuse edematous wall thickening of the rectum, sigmoid, and ascending density. It's all the large bowel. I want to check the ileocecal junction. The ileocecal junction is seen thickened. Still, there is no mass lesion seen at this site. I want to check if there is any skip lesion to exclude the.
So I have now given you a coronal. First of all, look at the large bowel. Just look at the large bowel.
The bowel lost haustration. It's lid pipe bowel shape. I can see the edematous wall of the all over the colon. I think this is maybe ulcerative colitis. There is no obvious obstructive mass lesion seen in the colon, in the large bowel. I want again to check the.
Okay, so your conclusion is?
I think this is an inflammatory process for the colon. This is, I think, ulcerative colitis. Small bowel, I want also to check to exclude if it's Crohn's, but I don't think it's Crohn's because it's not showing skip lesions in the colon, and it's mainly in the colon. And the colon has the thickened wall.
What is your differential other than UC?
My differential will be the Crohn's. Will be if it's maybe infective type, like there is if the patient has a history of antibiotic or has a history of chemotherapy, we have to exclude this toxic mega colon.
Okay, madam. Thank you. Thank you. I'll come back to you. Now, the first case is pancolitis, basically, and this particular pancolitis was UC, but there is a bit of differential diagnosis. A few teaching points, the background of this case. Now, the word megacolon should be in your vocabulary. Now, megacolon can be two types. One is non-toxic and second is toxic. Non-toxic means when there are no mural abnormalities, and toxic means when there are mural abnormalities. Now, toxic megacolon can be due to inflammatory bowel disease, both UC more likely than Crohn's, but Crohn's can also be kept in the differential. Other than that, infective colitis, especially pseudomembranous colitis and ischemic colitis. Now, if you see here, this is the normal bowel pattern of the transverse colon, which has got crisp and sharp haustra. There are haustral markings. So three types of findings, you can look for them when there is a dilated loop of transverse colon particularly. One is loss of haustra because they are thickened. Then thumbprints, you can see, for example, here or here or here are thumbprints. I'll show you another slide to show another, examples of thumbprinting. And there can be some projecting pseudopolyps, for example, this thing here, this thing here, this, which are projecting inside. They are mucosal tags. So these are words which we use for toxic megacolon. Toxic megacolon is a very important case. It can come even in rapid reporting. It can come in long cases. It can come in VIVA. Another thing is, key point is that when a bowel loop crosses the spine, then that is the classical location of the transverse colon. Now, this is classical thumb printing. If you see here, this is classical thumb printing, and this is how the word thumbprints is when you use a stamp pad. Now, there is a differential diagnosis for thumb printing itself. Please remember, thumb printing can be seen on plain film. They can be seen on bariums or gastrographins. And this is from the 6th edition of Chapman. In 7th edition, you will not find this thumb printing in the colon. And you can see all types of things, including the same things which were causing toxic megacolon here, and some tumors, etc., can also cause thumb printing. This is a case of pseudomembranous colitis, which causes more thickening than anything else. But please remember that this is not an absolutely specific sign. This sign, if you see here, the rectum is involved, just like our case, and from then onwards, everything else is involved. It's a pancolitis, and this sign is known as accordion sign. This is the musical instrument accordion. That is it. Now, key concept to remember is, this is what I was asking, what is your differential diagnosis? Key concept to remember is that which part of colon is involved. And so if diffuse involvement is there, pancolitis is there, then the differential diagnosis is, as we have already considered. When predominantly right-sided, this is the differential diagnosis. And then predominantly left-sided, the differential diagnosis changes. Please remember that ischemic colitis, if it is because of SMA, please remember this is an exam question, that SMA supplies the small bowel as well as portion of the transverse colon. So right-sided ischemic bowel, which will be usually associated with small bowel ischemia, but at times when there are embolic infarcts, it might not. Embolic ischemia, it might not. Can cause SMA, can cause that. And as far as left-sided is concerned, it is due to the IMA, which is distal to the distal portion of transverse colon onwards, and sometimes the watershed zones are involved. So with this thing, we go to the case. Now, candidate one, a bit of feedback for you. Please remember, when we do plain acute abdomen series, we do a supine X-ray and supine X-ray abdomen and a chest X-ray. The pneumoperitoneum is seen on a chest X-ray. On a supine, of course, there can be signs of free air on a supine film, which was this case about, but uh, you were referring to gas under the diaphragm. That cannot happen on a supine film. There are other signs. Second thing is that this is not the duodenum. This is the transverse colon, which is going overlying. There are no hostra, etc. And all of these findings were more or less confirmed on the CT scan. Now, please remember that the protocol to look at the bowel is that you have to concentrate from one end or the other end, and this is the stomach. We can see the stomach here, and then we can see the duodenum here. This is the D3. This is the pancreatic head, and this is correction. This is the D2, and this is the D3. And a portion of the small bowel might not be very well visualized on an axial sequence. And it's standard practice to look at it on a coronal, and even on the exam. In the exam, once you have seen it on an axial, you can ask the examiner that I want to see the coronal. Now, my practice is that as far as large bowel is concerned, I follow from the rectum, anal canal upwards. So this is the rectum. It is all thick walled. We can see the sigmoid, which goes right and left. And this is the descending colon. We go up all the way to the splenic flexure. And then the transverse colon, it goes to the other side. You can also look at, if you want, on lung window or bone window, whenever you have got a doubt for a loop of bowel. If there is a gas in the lumen or outside the lumen. This is the descending colon. And the candidate did well where was asking about ileocecal junction. So this was the ileocecal junction, which looks normal. Now, once you go through it, then you can ask the examiner that in my usual practice, I would like to see the the small bowel on coronal. If they have got time, they will show you. Otherwise, they will just ask you what it is. And you can see that it is very well seen. The small bowel is much better seen. And you can see the ileocecal junction here. Please remember that at the ileocecal junction, there is a bit of fat. And proximal to that, this is the terminal ileum. So whole of the small bowel is normal. And if you want, you can go for your, you can change the window to see, this is the lung window, and you can see the same thing which you were looking at on the plain film, where the transverse colon hasn't got any hostra. So it's not hyperacute. It's not, it is acute, but it is not very magnitude of inflammation is not too much. Okay, well done. Next case, please.
I'm presenting case of X-ray radiograph hip joint. I can see an osteolytic lesion in the shaft of the right humerus. With
Right femur, you meant, huh?
right
Humerus?
right femur. I'm sorry.
Right, yeah.
I'm sorry. Right femur is showing an osteolytic lesion. This osteolytic lesion is seen medullary in position. It's seen, it's involving the shaft and the greater trochanter. The lesion is scalloping the cortex and scalloping the cortex, and I think it's eroding the cortex. There is no obvious soft tissue. I think it's wide zone of transition. No obvious soft tissue. I think I'm not sure if there is soft tissue component outside. There is no. I can't see soft tissue component. This is a mature skeleton patient. So I think this is a aggressive lesion. Mostly maybe will be regarding to the age of the patient. This is maybe metastasis. There is also coarse trabeculation. There is a coarse trabeculation inside the.
Okay, so what comes to your mind then?
If coarse trabeculation, I think this is maybe Paget's disease involving the femur, the right femur. In my routine practice,
Okay, what is this? Okay, madam, we'll come back to that. What is this?
Sorry, I can't see. I can.
You cannot see?
Because 1 minute. Yes, there is a well-defined lesion seen in the left femur. This lesion, this is maybe bone island. It's
Are you
well-defined.
sure?
Actually, it's well-defined with the areas of calcification. This is maybe enchondroma. It's a medullary and well defined, has areas of calcification. So it's
Right. So what is your conclusion?
My conclusion for the left femur lesion, this is a benign lesion, maybe enchondroma.
And for the right one?
For the right one, I think this is maybe Paget's disease because of coarse trabeculation and expansion of the bone.
Okay, thank you. Bone island on left and Paget's disease on right. So let's discuss this. Now, what exactly is bone island? Look at the definition of a bone island. Bone island is a focus of compact or cortical bone located within the cancellous or the medullary bone. So this is the cortex and this is the cancellous bone, which is the medullary bone. And basically this bone sits here. Key points. What are the key points? It is dense. It fades at the periphery. So this is our lesion. And you can see that it fades. Just remember that word. It fades at the periphery. And there is merging with the normal trabeculae. I'll show you on DICOM just to blow it up and see that there are surrounding trabeculae. It merges with that. And then look at this word. It has got an edge which is brush-like. Look here, brush-like. Again, I'll show you on Osirex. On the other hand, Paget's disease, I'm not at all going to go into Paget's disease, the detail, which might cost me another 1 hour if I show you everything about Paget's disease. But please remember that Paget's disease has got various kinds of presentations. And this is what exam is about. Early presentation, late presentation, lytic phase, sclerotic phase, mixed phase, with complications like fractures or osteosarcoma, etc., etc. Paget's disease is extremely important for the exam. 3 things which are extremely important as far as the variety of presentations, one in bone, one is Paget's disease, second is fibrous dysplasia, and third one is hyperparathyroidism. I showed you, I think, 1 or 2 sessions ago, many cases of hyperpara. I can show you 10, 15 cases of Paget's, but that's not my aim today. But I am showing you early type of Paget's. This picture from StatDX tells you everything, what happens. So, loss of normal cancellous architecture. So the cancellous bone is inside. You remember the previous picture. This is the cancellous bone. Look at the trabeculae, right? And look here, how thick they are. There is loss of cancellous architecture and replaced by coarse, thick bundles of trabeculae. So this is what it is about. And then the cortex itself, it will also be coarse and granular. So these are the key findings of Paget's disease. Now, I don't want to go into details, which you can read yourself, but one point I want to make is that early lesions can be lytic thin cortex, then later on mixed lytic and sclerotic. So everything can happen, and then disordered thickened trabeculae and cortical thickening. So once you know this pathophysiology, you can make the radiology. So this is a full-blown case of Paget's disease, where just to highlight how the cortex is thick, and then is bone expansion. In our case, the bone expansion was not to that degree, because that is also pathognomic for Paget's disease, bone expansion. But having said that, please also remember one key thing about Paget's disease is that it extends all the way to the articular surface. It goes all the way to the articular surface. One exception to this rule is tibia, where in tibia it might go to the superior tibial tuberosity and might not go to the articular surface. So this is about Paget's disease. Now let's go back and see the case. Now, first of all, let's see the right side. Now look at the trabeculae, how coarse and thick they are. It's quite a unique finding. You will not see this finding in any other condition like this. And then cortex, even a lucency in the cortex, slight bit of expansion here, slight bit of expansion should not bother you. If you look carefully, try to see, let's see the trabeculae on the normal side, which is this one. Just concentrate here, and look at these trabeculae, concentrate in the subarticular region, which is, just inferior to the joint. And you will agree that actually early coarsening of trabeculae can be seen extending all the way here. It's not all that fine. So, of course, this patient will develop more advanced Paget's disease in the coming years. Now, as far as our bone island is concerned, just see how classical it is. That it has dense, look at the margin, brush-like margin, and it merges, it fades at the margin and merges with the adjacent trabeculae. So these are two different cases, two different pathologies, just for discussion. Okay, let's go to the next case. This patient, candidate 1, this patient, what happened was that the the gastroenterologists, they were doing a colonoscopy, and they felt that there is something extraneous. These were the clinical notes, which was compressing the rectum, and they asked for an MR when they did a colonoscopy. So I am scrolling for you. Let me scroll up and down, and then you can give me your initial impression. So I've gone up. Now I'm coming down once again.
I can see this is a MRI. This T2 sequence showing well-defined, well-circumscribed cystic lesion, showing heterogeneous texture, heterogeneous content. The lesion is seen compressing the rectum, compressing the anus and rectum. Lesion is seen well-defined. It's not well-defined with good fat planes with the pelvic muscles. Also, although it's compressing the colon, but it's not invading the rectum. In my routine practice, I'll check the lesion on the T1 fat set to know the content if there is blood or fat signal inside this lesion.
So signal inside was low signal on T1.
If it's low signal on T1, this is excluding blood and excluding fat content. So this lesion may be enteric cyst because it's a benign looking lesion.
Okay, look at this one. I have given you a sagittal.
Okay. Maybe also, no, this is away from. This is, I think it's maybe, also we want lesion is away from the spinal cord and the foramina. So this is excluding neural lesions, neural origin lesions. So this is maybe if it's also it's not teratoma. So I think this is maybe enteric cyst.
What is the sex of the patient?
Sex of the patient, it's I think it's male.
Male patient.
Male patient because he has a penis here. So
Yeah.
he is male. Maybe there is another also differential diagnosis, but I am hesitated because it's not. I may be seminal vesicle, but it's behind the colon. So like it's
Where is
away.
the prostate? Where is the prostate?
Prostate should be in front, not behind. Like.
Do you see the prostate?
No, I can't see the prostate.
Okay, we did a CT for this patient. This is the CT finding.
There is calcification inside the lesion. Calcification.
This calcification, the density was quite high. It was sort of a metallic type of density.
Does patient have any history of surgery? Like if the patient has any history of surgery, this is maybe a metastatic recurrence from prostatic cancer after removal of the prostate.
Okay, madam. Thank you. Thank you.
Oh.
So, yeah, it came to your mind as you were, you can see the diagnosis.
Yes.
So this is a gossipiboma. The patient had prostate surgery. I will come back to you. The prostate was not visible on that MR, and this makes it a story case. The case tells you a story. These are favorite for the exam. A case which tells you a story. You have to sort of think what the story is. I'll come back to the case. This is another case of a gossipiboma. Basically, gossipiboma, the word gossipiboma means gossypium, the Latin word for cotton wool, oma is a tumor. Some people also use the word textiloma, and this is another case. This is not this case, this is another case. Now, basically, please remember that it is a sort of a never even type of a thing in UK. But over the years, I have seen quite a few cases, and many of them have been operated overseas. Basically, please remember now the protocol is that they use gauze. Gauze, the surgical gauze which is used has got thread. This thread is barium impregnated. So there is barium there. What is the concept? In the theater, they are extremely diligent on this. There are protocols about it. How many cotton swabs were used? And the nurses, they will count it, they will recount it. And after everything has been done, they will count it again. And suppose if there is a discrepancy in the counts, then what happens is they take X-ray, on fluoroscopy, on the image intensifier, which is available in the theater, and they try to see it. So that is the concept of barium impregnated thread, so that it can be seen in a patient, on the table, live on the table. Now, what happens is that these things do happen. I have, in my clinical practice, I have even seen forceps, artery forceps being left inside, and people traveled from overseas with the forceps. I don't know how did they pass through the customs, etc. In any case, now, in this particular case, just one second. So this is another example from literature. So the radiological features depends, they will vary. One of the radiological feature is that you can imagine, there can be air inside, air might get trapped inside, and they might get trapped inside forever. They can be inert, means the patient, there are case reports where people have done case report 37 years down the road, swab was found inside. So it can be inert. On the other hand, it can cause acute infections, etc. And beware of something else. Many a times they can fistulate. So fistulate from one part into another part of the gut, and patients have vomited these, because of fistulization, and they have also passed it through the feces. So these kinds of things have also happened. But the gas bubbly type of appearance, that's the most common. Otherwise, the appearances can vary. Key point to remember is that on MR, you cannot diagnose it on MR because it will be very unusual. When you look for it, ask for a CT. On CT, look for this high density barium. It is metallic, so it gives you this artifact. Once you have seen that, you have got your diagnosis. Now, if you see here, let's go back to your case. Now, here, nobody can diagnose it just on this basis, but this is the rectum. It is displacing the mass. Mass has got, unique type of appearance, honeycombing type of appearance, but there is some fluid, etc. It looks a benign type of a mass. Key thing is here on axial also, your mind should have gone to this thing. Is it male or female? If it is a female, then where is the vagina? If it is male, then you have to see the prostate. It's missing. And then on sagittal, it is absolutely clear that the prostate is not there. What does it tell you? The story. The story is that the patient has had prostatectomy, and this prostatectomy was 8 years ago. And then we did a CT scan which showed this. This is absolutely pathognomic here. You see thread shape, and look at the density, look at the artifact it is producing. So this was a Gaussian poma. Okay, then next case, please. Candidate 1, this is your last case. Over to you.
Great. I'm presenting case abdominal radiograph showing a soft tissue lesion in the left hypochondrial region. The soft tissue lesion is showing punctate of calcification. There is I want to check the bone. The lesion is showing, first lesion is I think it's seen inseparable or covering the psoas muscle in the ipsilateral side, left side. I want to check if the lesion has any relation with the surrounding bone or any other metastatic lesions. I can't see any lesions in the vertebra. Also, I see the visualized ribs are seen normal. I can't see certain lesion. The lesion also displacing the bowel loops into the contralateral side, to the right side. In my routine practice, I'll proceed into a CT abdomen to check
Right.
the.
What is this?
This is I can see for focal mixed lytic sclerotic lesion is seen on the right, on the left. I'm sorry, in the left iliac bone related to the acetabulum. This lesion is maybe as it has high trabeculation. This is maybe either Paget's disease or metastatic from the upper, the left soft tissue lesion. Maybe it's metastatic from the soft tissue lesion.
Okay, I have now given you a CT scan. Now, because you cannot scroll it, I am going to scroll it coming from the lung down.
Okay. I can see pleural effusion and the soft tissue lesion is seen on the in the intercostal region. Multiple soft tissue lesions. In my routine, I'll check check lung window to see if there is any other lesions in the lung. Okay, there is a collapse for the left lung collapse, and there is also a nodule. I can see a nodule seen in the base lung. Okay. Then I want to check the abdomen at the area which I saw the soft tissue lesion in the right hypochondrium. In the left, I'm sorry, in the left hypochondrium. This is the right. It's the right. It's the left. The left kidney is showing a marked hydronephrosis with areas of thinning out of the cortex. This is associated with surrounding congested fat planes. I want to check if there is the cause of the obstruction of the kidney. Again, I want to, there is also this osteolytic, mixed osteolytic lytic lesion seen on the in the left iliac bone. This lesion is showing soft tissue component, and it's affecting the iliac the posterior part of the acetabulum and the iliac bone. Also,
Conclusion.
conclusion here. This is maybe a metastasis. Um, I want just this is maybe a metastasis of the renal. This is not hydronephrosis. This is a lesion in the kidney. This is maybe RCC with metastatic bone disease. And also there is a nodule in the nodule in the lung, and
Okay.
and there is
Thank you.
also
Thank you very much.
subcutaneous nodules, I think.
Subcutaneous nodules. Okay.
Oh.
Thank you. Now, renal cell carcinoma with bone mets. The idea here is there are metastases which cause what we call blowout bone metastasis or expansile bone metastasis. Whenever you see them, the top two tumors are renal cell carcinoma and thyroid carcinoma. Otherwise, hepatocellular carcinoma, pheochromosomal melanoma, gastric carcinoma. Now, these two should be up there. And there is an appearance, we call it soap bubble appearance. Soap bubble appearance is also, particularly in pelvic bones, look for these two. Now, if we go back to this case, the key findings here are that there is a mass here which is obliterating the left psoas muscle. So it might be of renal origin or which is what the candidate pointed out. Now, there is a lesion here. Now, immediately, once you pick up this lesion, initially, the mind goes into this. Is it a geode? Because there can be subarticular, there are OA changes here. Is there a geode? And you look carefully, and on you can see that there is expansion, there is a bit of lucency, a bit of bubbly appearance. This is not at all a geode, it's more than that. So this is a classical appearance of, a bubbly metastasis. Now, this particular case, I am showing you, this is a classical case, actually not for a VIVA, but for a long case. There are many types of cases which come in long cases. And one of the type is, as I am showing you, where the case is simple, but the findings are multiple. And everybody is going to pick it up that this is a RCC, and most of you are going to pick it up that this RCC has got bony metastasis. But, look for everything very carefully. Once you describe the RCC, see if, the classical description of an RCC, because please remember RCC, they go into the renal vein. And from the renal vein, they go into the IVC. And from there, they can even travel all the way up into the left atrium. And that is an exam case. So that should be your pertinent negatives that, the renal vein. Now, this is the renal vein. And in our case, it's not going into the renal vein. Otherwise, what it is doing, where is the adrenal? So the adrenal is fine. It is not going into the adrenal. But there are multiple nodules. For example, even this is a nodule. There are multiple peritoneal and retroperitoneal nodules. Look at this nodules. Now, if you go up here, look here. This is a nodule here. there is a nodule here. Of course, the candidate did pick up lung metastases, which were sitting, here. But the fine touch of it is, look at the left-sided effusion. Now look at the pleura, and you will appreciate that the pleura has got nodular appearance, enhancing nodular appearance. Look here, how nodular and enhancing it is. Look here what is happening. And this is causing effusion. So somebody who has mentioned that nodular, pleural metastasis will definitely get half a mark more, isn't it? This is how the examiner is going to discriminate between those of you who will get 6 and those who will get more than that. So this is satisfaction of search case. Easy case, but multiple findings. To pass this case is very easy, but to get more marks, you have to highlight each and everything. Now, there are upper abdominal lymph nodes. There is para-aortic lymph nodes. There are, as the candidate also pointed out, there are soft tissue nodules. So here you are. You see these nodules are soft tissue nodules. As far as bone is concerned, this is a classical soap bubble. This is a classical soap bubble lesion. If you see this, this is a classical soap bubble lesion. But having said that, we can see further metastasis. Further metastasis, for example, another soap bubble is here. And if you go for a sagittal, if they have provided you with a sagittal, you go for it. On this sagittal, there is spondylolysis grade 1 with bilateral spondylolysis with listhesis. And we can go right and left, look for anything happening in the ribs, and you might pick up something. Actually, there is a lesion here in the ribs. So why I'm showing you this case, it's an easy case, but these kinds of cases, they come in the exam for satisfaction of search and multiple findings. As far as soft tissue is concerned, another thing is that around the bladder, there is a lot of fat stranding. So there must be some infection as in cystitis, etc. happening. Okay, candidate 1, thank you very much. Candidate 2, are you with us?
Yes, Dr. Kanwe. I'm here. Good evening.
Good evening. Yes, please. Over to you.
I'm presented with frontal radiograph of a child. I cannot see the femoral heads, so this child, I'm assuming that child is less than 6 months of age. There are abnormal confluent periosteal reactions seen involving both the diaphyses of both tibiae and in the left fibula as well. The periosteal reaction is not extended to cover the epiphysis. It's only on the diaphysis. The bone density is maintained. There is no loss of bone density. In my routine practice, I will window a little bit the radiograph to check the bone and magnify the image, and also see the lateral view as well. So the distal femoral epiphyses and the proximal tibial epiphyses are normal. The metaphysis looks normal. So I would like to confirm the age of the patient. If this patient is less than 6 months, this could be presented with pain and swelling.
What do you think is the age of the patient? What do you think?
I think is 6 to 8.
Why do you say 6 to 8?
Because the femoral heads are not there. It's not.
So what is the age at which the femoral head epiphyses appear?
6 months, 6 to 8 months.
Okay.
So I'd like to see the. So in this patient has pain and swelling over the the lower limbs. This could represent infantile cortical hyperestosis, the Cafe disease. Although I would like to review also the reps and the clavicle and the mandible because it's most common in this side. The other possibility would also include prostaglandin E administration due to abnormal congenital heart disease, which kept beta ductus arteriosus patent. So this is another possibility. Other differential, but not in this age, thyroid, and but it's not in this age group. So I'd like to review the clinical, the lab, and the clinical history of this patient, and see also if there has any previous imaging. The other possibility also could be a primary pachydermoperiostosis also, but usually it covers the it doesn't extend to the metaphysis as well.
So anything else in the differential?
It's not classic for scurvy. Could be due to subperiosteal hematoma, but it's not very typical for it. There is no tumor field zone. Wimberger sign are absent, but could represent also subperiosteal hemorrhage as well.
Anything else?
Can I see the lateral view if it's available, or ribs?
That is not available. What is your differential just on the basis of this X-ray?
So infantile cortical hyperestosis, Cafe disease, and prostaglandin E administration, and primary pachydermoperiostosis.
Okay, thank you. I'm going to spend a bit of time on this one. This is my favorite differential diagnosis in Chapman. And so I teach a lot on this. And the idea how to tackle a case, actually this can be a presentation itself. So, but I'll keep it short. Now, Caffey's disease. Now, just slightly come out of the case, and the top take for FRCR exam in the exam is that regarding the differential diagnosis cases is that the examiners want to hear the differential diagnosis in that case which they are showing you. They do not want you to regurgitate the list from Chapman or from wherever you have learned it. Candidate did very well, but slightly off target, which I will highlight. Slightly off target, but at least did not, enumerate everything. Now, whenever you get a differential diagnosis case, I define it like this, that your theoretical knowledge, left side of the brain, your differential diagnosis in the right side of the brain. And as you are talking, the differential diagnosis is coming into your mind. And you start actually, using pertinent negatives. For example, you remember in this case, when I asked, the candidate said scurvy and then immediately gave pertinent negatives. So I like that because of this, it is unlikely to be scurvy. So you have to really train your mind on this. So the differential diagnosis list should be in your mind. You should remember the list, but tell the examiner what is relevant in that particular case, according to age, sex when it is relevant, location of the lesion, and the radiological features. If you regurgitate whole of the list, you will be penalized. Remember this. For example, a classical case of simple bone cyst, what else can it be? Sometimes the examiners are going to grill you. What else can it be? And so the method is that even if you say something, then rule it out that because of this, I did consider this, however, because of this, it is not this. But if you do this kind of a mistake where you say on a simple bone cyst and the examiner is asking, can it be malignant? And you lose your confidence and you say it can be malignant, then you will be penalized for that. So remember that. So whenever in that scenario, be confident. If challenged, be confident. This is an extremely important message, and there is no shortcut to have this confidence. You know, it takes 2 years of training your mind on differential diagnosis and doing a lot of hot seat sessions in your department with your colleagues or your, your teachers. Please remember that some cases will be for discussion only, and I could have gone on discussion in this case if I wanted to. Now, this differential diagnosis is periosteal reaction bilaterally symmetrical in children. Do not confuse it with periosteal reaction bilateral symmetrical in adults, which the candidate did, because pachydermoperiostosis, etc., that is another age group, Age is critical. In this differential diagnosis, two things which I want you to add include non-accidental injury and hypervitaminosis A. I will quickly show you the salient features of all of this, and then we will have a discussion on the case. So please remember that you have to remember this differential diagnosis, number one. Number two, in the left side of your brain, you have to remember the main radiological features. First of all is physiological. So you see here, normal infant means physiological, juvenile idiopathic arthritis, acute leukemia, rickets, Kefi's disease, scurvy, prostaglandin E1 therapy, congenital syphilis, and then I have added to it non-accidental injury and hypervitaminosis A. So all of these should be in your mind. And I'm quickly going to show you the features of all of this. In today's lecture or today's session, this is the main component where I'm going to do a bit of teaching. Now, this is a 7-week-old baby, and typically these are less than 4 months. There is periosteal reaction, subtle periosteal reaction, usually upper diaphyses of ulna, bilateral symmetrical, you see here and here. So these are and our case was not at all like this. Now, look at this one, JIA. It should not be even considered in the differential diagnosis. In JIA, what happens is that there can be periosteal reaction around multiple phalanges, and there can be soft tissue swelling. So, for example, there is periosteal reaction, periosteal reaction, periosteal reaction. Look at the age. Age is 2 to 4 years. Our case was less than a year. I'll come back to the case. Now, let's go to another thing, acute leukemia. Acute leukemia is a bad condition. We know that leukemia, when it will involve the bone will not be normal. In our case, the underlying bone was normal. But key point is, even before that, is the age, 3 to 7 years. It cannot happen in our age group. And you can get this bone is known as a moth-eaten bone. Moth-eaten bone is per se a differential diagnosis for the exam. And you can see that there is periosteal reaction, and it can be bilateral also. Then comes rickets. Now, rickets is interesting. In rickets, what happens is, can there be periosteal reaction in rickets? It can be what we call a pseudo-periosteal reaction, might not be seen in each and every case. Remember this. But I'll come back to that point. the typical age group is 3 to 18 months initially, usually in the wrist. Then when the toddler or the child starts walking in the knee joints, etc. Basically, you are looking at distal metaphyseal cupping. And what is this? Pseudo-periosteal reaction along the shaft of both tibia, and there can be bowing of tibia and femur. What is pseudo-periosteal reaction? Please remember, you will not see it in each and every case. Remember this. But in some cases, you can see it. Look here, you can see this periosteal reaction, and maybe here also. What happens is, if you go back to your normal metabolism of bone, where in a child, there is growth, osteoclastic activity under the periosteum. So there is new bone formation. It is normal physiological. But this new bone is devoid of calcium, so looks like lucency, and overall gives you an appearance of pseudo-periosteal reaction. So that is why rickets has been given in the differential diagnosis. And then we go to next case. I don't want to go into details of this, but it is beautifully summarized in Chapman in page 614. See this diagram and please revise everything on rickets. From there, we come to this is Kefi's disease. Now, Kefi's disease, by the way, our case was also Kefi's disease. The candidate did very well. The candidate asked for clavicle and mandible, etc., and that is what it was. Look at this case. This is an exam case where there is periosteal reaction along the diaphysis, thick periosteal reaction. Look at the clavicles. Clavicles are involved. Clavicle right and left is involved. You cannot see the mandible, but actually there is a bit of thickening of mandible. And typical age is less than 5 months. So it starts less than 5 months. I'll come back to Kefi's disease. It is idiopathic without any reason. Periosteal reaction along the distal radius or left ulna on right side. So I'm just reading it. Actually, this is whatever is written is the findings are here. Now, then comes scurvy, another differential diagnosis. Scurvy is very interesting. This is scurvy, and you should read it from your Chapman. There is a concept of book memory. Even if you have read scurvy from any other site, any other resource, read it from Chapman 623. There is a diagram there, and you will remember it in your mind. Wimberger sign, which is reduced epiphyseal density, pencil-thin cortex, all of the other things. What happens in scurvy is that sometimes, not in all cases, please remember, not in all cases, there can be hemorrhage under the periosteum, which causes this periosteal reaction, this hemorrhage, periosteal reaction. Key point to remember, it cannot happen less than 6 months of age, because the child has got enough vitamin C through the mother. Then we go to prostaglandin E1 therapy. Case from Radiopedia. Basically, the concept is that these patients, they present with cyanotic congenital heart diseases, and they want to, the patent ductus arteriosus, they want it to continue, and at a later stage, they might do surgeries, etc. And for reasons which are not very well known, it causes osteoblastic activity and lot of periosteal reaction right and left. Another thing which, for unknown reasons, the sutures, they are widened also. So there can be periosteal reaction all along. This is one of the differential. And then comes NAI. NAI, where you will see metaphyseal corner fractures, and then hypervitaminosis A. In hypervitaminosis A, there can be periosteal reaction, thin periosteal reaction. Typical age group is more than 6 years. And then comes congenital syphilis. Please remember that syphilis has got a rebound as far as numbers of cases are concerned in UK. And of course, overseas, it is much more common. And you can see these kinds of cases. Key finding in congenital syphilis is that other than periosteal reaction, you will see metaphyseal erosions. You see this aggression, metaphyseal erosions. Now, once all of these things are in your mind and the case comes in your exam, then you can simply go through them one after the other in your description. As you are describing, you will rule it out. When the examiner grills you, you can simply defend yourself and do not agree on any other differential and be very emphatic, get maximum marks. Now, a few things about Kefi's disease. Kefi's disease is idiopathic infantile cortical hyperostosis. Age of presentation is about 9 weeks to 5 months, so less than 6 months. There will be hyperostosis. Where will be hyperostosis? Many bones are involved, but the candidate did very well. Mandible is one of the pathognomic. Mandible, 80% of patients have mandible. The patients will, of course, a young child, the word pain is difficult to, elicit or mention. The patients will be very, irritable. They will cry. They will have thick skins. And look at the clavicle. And the scapula can be involved, not in our case. The ribs can be involved. So whenever you get this thick periosteal reaction along the diaphysis, remember this, along the diaphysis, epiphysis are not involved. Ask for mandible, ask for clavicle, and this is what it is. What is the natural history of Kefi's disease? Kefi's disease is a self-limiting condition. It can cause a bit of deformity as in bowing, etc., but gradually the child grows out of it. So this is Kefi's at 5 months, then 6 months, then 12 months, you have become better. This is periosteal reaction in another case of Kefi's disease. And this is another case in which there is periosteal reaction. Look at the clavicle, and this is the periosteal reaction, and look at the mandible. As if from here to here is the thickness of the normal mandible, from here to here is periosteal reaction. You can see how thick it is. So coming back to the case itself, so in this case, first of all, age. Please remember the age you are going to tell the examiner. You cannot ask the examiner. Why? The epiphysis, femoral head epiphysis, is not visible. What is the normal age of appearance? In girls, it is 2 to 6 months, slightly early, 2 to 6 months. So 6 months is a good point to remember. In boys, it is 3 to 7 months, but there might be a subtle discrepancy in various sources. So generally speaking, even in boys and girls, it cannot appear maximum 6 to 7 months, it will appear. So this is a child which is definitely less than 8 months or close to that. With that, you have got a periosteal reaction which is thick, and this thick periosteal reaction is along the diaphysis, and it is not involving the epiphysis. With that, there are pertinent negatives. There is no metaphyseal erosions. There is no, the scurvy, rule that out. No Wimberger signs and Pelkan spurs and Trummerfield zone, etc., etc. No cupping, as in rule out rickets. And of course, ask for a mandible, etc. But all said and done, there cannot be anything else other than, I think prostaglandin, you can keep it in the differential. Other than that, other conditions, because of the age group, it cannot be considered. So this is a very good exercise, very good differential diagnosis, which is a landmark differential diagnosis, a flagship differential diagnosis to learn the art for your exam. And candidate 2, you did very well, but please remember, pertinent negatives you should have spoken there and then. And pachydermoperiostosis is adult. So please remember that.
Okay.
Okay, thank you. Well done. Now your next case. My Osirix has collapsed. So let me share it again. Right. So this was your case. And now we go to what is happening. Can you see something?
Yes, I can see a axial T2 abdomen.
Right. Okay. So let me go through it. This is a case in which 26-year-old female, they did a community ultrasound, and they said that there is a simple cyst in the left lobe, and they said that there is a focal lesion 1.2 centimeter in right lobe, and because of that, an MR was done. Now, we can see the cyst here, so I don't want you to worry about the cyst. And we can see this is the right lobe, which I am showing you.
Dr. Khan, please, the image are so blurred. I think this is a different, yeah, this is much better now, yeah.
It is much better?
Yeah, now it's good, yeah.
So I'm showing you a T2, and there is something here. I don't want you to talk till now. Forget about the cyst. And please remember, it's a 26-year-old. Now we go to, oh my God, it has gone out, isn't it? Just one second.
Yes.
Let me sort it out. Okay, now
we're back to the blurred image again, I think.
I'll stop share and do.
Yeah, no.
Just one second.
Yeah, sure.
I think the quality is fine.
Yeah. Now the image is good. Yeah.
Okay. Now
yes,
the quality is fine.
Looks yes.
Now I am unable to present all sequences together, which I was aiming to. So because of the time factor, I'll talk you through it. Now, which phase is this? Can you ask me? Can you tell me?
This T1 portovenous phase, post contrast T1.
And
fat
in
saturated
and
in portovenous phase. Yeah.
this is the mass,
Yes.
right?
Yes.
So what is it doing? It is enhancing.
Yes.
This is a pre-contrast T1 weighted sequence. On the pre-contrast T1 weighted sequence, this is the lesion.
It's slightly
And
high. Yeah.
then we have got a, if you see here, this is the cortex and this is the medulla. It is not exactly a venous phase. It is a late arterial, early venous type of a phase, right?
Yeah.
Now, in that phase, we can see that it is enhancing. What is your differential diagnosis till now?
So in the early arterial, it's enhanced, significant enhancement could be flash hemangioma. First possibility. I would like to see it on the delayed also image to check if this wash out or no wash out in this image.
Right.
So this is out of phase.
And what is the appearance on out of phase?
The out of phase, there is a drop of signal, I think, on the liver itself, which means there's some fatty component or fatty liver or steatosis.
Right.
And the lesion
So
itself
we have got another phase here.
This is the arterial. Yeah.
Now look at the cortex and medulla of.
This is the late phase, I think.
It is venous phase. That was a
venous. Yeah.
Yeah. Now this is the lesion.
Yeah, still enhanced.
Yeah.
Like the portal. So
yeah.
Follow the portal phase. So I'd like to see it on the delayed.
Further delayed phase.
Yeah.
This is further delayed phase.
So they are centripetal filling. I think it's benign. There is no washout in the delayed image, delayed sequence. So this excludes the possibility of malignancy. So this could represent a flash hemangioma, rapidly filling hemangioma. There is also central scar. I would like to see it in further delayed image if it's enhanced or not, because this might represent also FNH, focal nodular hyperplasia, with enhanced scar in the late phase.
What do you mean by late phase?
I mean 15 to 20 minutes.
15 to 20 minutes?
Yes.
Which contrast media will you use for that?
I can use Primovest, hepatobiliary phase like this one. And this one, there is common bile duct secretion of gadolinium.
No. Excuse me. So I'm just listening to you. I'm showing you something else, but don't talk on the sequence. Just, it was a theoretical question. What did you?
So I'd like to see the enhancement of the scar of this central hypo-intense signal, central hypo-intense signal.
What is your differential diagnosis before that phase? What is your differential diagnosis?
Differential diagnosis would include a flash filling hemangioma. I would like also to see the arterial, also to
this is the T2 weighted sequence, and this is the lesion. It is. Do you still want to keep hemangioma as your?
No. Now it's low. So excluding hemangioma now, it's a focal nodular hyperplasia. Could represent a focal nodular hyperplasia or adenoma.
Adenoma. Okay.
The differentiating agent is a Primovest. We can use it. So in the FNH, it will drop signal on the Primovest, and it will not enhance because it will enhance. Sorry, because it will take the contrast. But in adenoma, it will not take the contrast.
Okay. Now, hypervascular focal lesions in the liver are very important for your exam. And please remember that, of course, the world is more complex than what is on this slide, but just remember what is here, and you cannot go wrong with this. Now, it can be benign and it can be malignant. Benign FNH, adenoma, hemangioma, and malignant HCC, mass forming or intrahepatic cholangiocarcinoma, and hypervascular metastasis. Please remember that one of the key what we call concept is washout. So on MR, there is an early phase, which is arterial. It is slightly delayed than a classical, what we call a CT angiogram phase. It is slightly delayed. And that is why you might see a bit of portal vein also. But look at the kidney and you will see that the cortex and medulla will be different. Arterial phase, then venous phase 70-second, and equilibrium phase 3 to 10 minutes. Now we utilize this on MR. On a CT scan, we cannot utilize it, otherwise we will roast the patient with radiation. So we cannot do too many. Now, the key point is that if a lesion washes out, wash out means it becomes darker as compared to the parenchyma. That is taken as a bad sign. On the other hand, if the patient does not wash out, look here, it is enhancing, and venous phase still enhancing, it is still retaining contrast, then it is a good sign, it is a benign lesion. On the other hand, a malignant lesion, look at this, this is a metastasis, arterially enhancing, then even here you look carefully, it has shown some washout, and here the washout is very clearly seen. So once you pick this up, means malignant, it can be a HCC versus metastasis and cholangio, etc. Now, on the other hand, there are other concepts which you can, on MR or clinically speaking, you can use this. Hemangioma, there is a particular type of hemangioma, we call it a flash hemangioma. That will be bright on T2 weighted sequence. It might show restricted diffusion on DWI sequence, and the signal intensity will be equal to blood pool on all phases. So if you look inside the lesion, the signal intensity will be equal to the blood pool, means the portal veins and the hepatic veins. Now, FNH versus adenoma is a very important discriminator. Please remember, pathologically speaking, FNH is not a neoplasia. The concept of FNH is that this is a hyperplastic response to a vascular malformation. So there might be a large artery sitting inside the scar. Those kinds of cases are also, you might see them. And on the other hand, adenoma have, there are multiple types of adenomas, and one of them, they have got a concept of malignant transformation. Key point is, and adenomas can also come to you with bleeding. So the key concept is that adenomas, you have to keep an eye. At times you advise surgeries. And in exam scenario, please remember an adenoma which will come to A&E with spontaneous bleeding. FNH is a very good news. And once you diagnose it, then you forget about it. So this sign can also be seen on contrast ultrasound, by the way. We call it black is bad sign. And please remember, in the real world, there are some pitfalls of these washouts, etc. And some of the tumors, they do not behave what I have told you. That's a disclaimer. Nothing in radiology is perfect. We should understand that. But adenomas, fibrolamellar HCC, cholangio, HCC capsule, etc. There are pitfalls, but I'm not going into the details of this. Now, coming back to MRI, candidate to, you should have asked, that because this is not done routinely, right? You should have asked that I want to, instead of me asking you, if you want to check this, you will say, usually MR liver is done by using normal gadolinium. We call it extracellular agents. And sometimes we can do hepatocyte specific agents. So in the world, there are two hepatocyte agents which are right now in vogue. In UK, we have got this one. This is from Bayer. It is known as Primovist. In USA, it is known as Uovist. The key feature for you to remember is that it has got a hepatobiliary phase. Key feature is that 50% of this is excreted through the liver, but it takes about 20 minutes delayed phase. So you must do delayed phase. And key concept to remember, so forget about this one because we don't use this. This is 60-minute delay. We just use this. And this is the usual protocol which we follow. Of course, there can be some variations. We do T2, highly T2 weighted in an opposed phase, to look for fatty, and the candidate did very well, picked up fatty change in this case. Then we do diffusion weighted sequences. We use various kinds of B value. Look at the highest B value. This is the ADC. ADC is too grainy. Usually we just eyeball it on diffusion. Anything which remains bright on highest B value, this can be a sign of malignant lesion or it might be a hemangioma. Please remember that hemangioma is a benign lesion but will show high signal on high B value, just like this spleen. Now, after that, we do a fat-saturated T1 pre-contrast. Then we use an auto-injector. We give and we do arterial phase, venous phase, 3-minute delay, 5-minute delay, 10-minute delay. This is with usual gadolinium. When we are using hepatocyte-specific contrast, then we use a 20-minute delay phase in which it excretes. Please remember that the key concept is that FNH have got normal hepatocytes. There can be a central scar, but otherwise there are normal hepatocytes which can show excretion on the hepatobiliary phase. Adenomas do not behave like this. So till delayed phase, till 10 minutes, adenomas and FNH, as far as just contrast enhancement is concerned, there will be arterial enhancement and no washout. So now you are sure that this is adenoma or FNH. And it is not an flash hemangioma because of other features which I told you, like high T2 value, restricted diffusion, etc. Now, then you do a hepatobiliary phase to discriminate between the two. This is from literature, from StatDX, where you can see that this is an FNH and this is a hepatobiliary phase where it retains control, the central scar does not. Please remember, many FNH will not have a central scar. So it's not a must for this thing to have a central scar. This is again from literature where the lesion is arterially enhancing. There is a central scar. And central scars, by the way, can be in more or less every tumor. Now, it does not show washout, but on hepatobiliary phase, it shows washout. So here it is benign, and then it is an adenoma and not an FNH. This is a case in which the patient had breast carcinoma and multiple focal lesions on imaging. They were worried about metastasis, but on hepatobiliary phase, you can see contrast retention means these were multiple FNH. So coming back to our case, now this lesion was low signal on T2 weighted sequence. Then we have got this is a in phase and this is a post phase. A post phase, you have to develop your eyes. Examiner is not going to tell you this is in a post phase. You have to pick it up. How will you pick it up? If you look at the outline of the various organs, they have got a black line, and this is known as India ink artifact or etching artifact. Look around the spleen, around the kidneys, etc. And we can see, actually, you should have access to both side by side, but you can make out that this is the signal intensity of liver. And on the opposed phase, it becomes black, means it is a lot of fat inside. So there is fatty change. Now, this is pre-contrast T1 weighted sequence. It is fat saturated, and this is the lesion somewhere here. And then we have got arterial phase, and on arterial phase, if you see, look at the cortex and the medulla, there is differentiation between the two, and the lesion enhances. Though there is blood in the portal vein, so this is what we call a late arterial phase. And then we have got a venous phase. Look at the cortex and medulla of the kidney, and you will appreciate that they have become, of similar intensity. Now look at this thing is retaining contrast, and we have got more delayed. We have got 3-minute delay. We have got then 5-minute delay, and we have got 10-minute delay. Now and finally we have got the 20-minute delay. In 20-minute delay, first of all, you have to develop your eyes. How will it behave? You can see that the CSF, the CBD, has got a high signal. And this is excretion of contrast. And you can see that the gallbladder has got some bit of contrast. You will see a bit of contrast in the duodenum also. Now, on this phase, you can see that there is some enhancement, retaining of contrast, and the central scar is not retaining. So this is an FNH. So please remember, FNH is an exam case. Hepatobiliary specific contrast, though you might not have seen in your day-to-day practice. The problem with this is it is about 118 pounds, this one bottle of this. And the other one, I think, is 9 pounds or 11 pounds, something like that. It's very expensive. You cannot use it with each and every case, but it has come in the exam. You should know this concept, and you have to ask the examiner that I want to see it on this phase.
Dr. Khan, please, can I ask a question, please?
Yes, please.
In MITS also, can we have some uptake in the Primovest in the delayed phase?
No, not at all.
Even peripheral, we cannot find. Okay.
No, never. And by the way, now we use hepatobiliary specific contrast. Just remember the main physiology and the pathophysiology you can make up. If there are normal hepatocytes, it will show or retain, it will show high uptake on hepatobiliary phase. A HCC will not have normal hepatocytes. A metastasis will not have normal hepatocytes. Now we have started using hepatobiliary specific contrast in, in cirrhotic nodules, particularly if there is a suspicion of HCC. And we have, as a routine in difficult cases, we use this because it will be a filling defect. It's a very black and white word. And the filling defect means metastasis. And please remember colon cancers. In colon cancers is one cancer where if there are liver metastases, they will remove the metastasis and they will remove the cancer, and the results are very good. So they want to know the segmental anatomy, and we now some of the studies have told us that it should be used, and we use it as a whenever needed. In Lyrad's classification of focal lesions in cirrhosis, etc., this is now known as an ancillary feature, and so hepatobiliary specific. Just remember, there are no hepatocytes. It will be black. Black is bad.
Yes.
Black
Yes.
is bad. So that is how it is.
So Lyrad system also, Dr. Khan, are used in UK or not? Lyrads.
No, we don't use it. Nobody is going to ask you, but I just mentioned it because if there is in clinical practice, that is slightly beyond 2B. FRCR world is a FRCR world, and that's why I don't teach beyond FRCR. That is slightly beyond. But the point is that in a cirrhotic nodule, if it is an hyper enhancing lesion and you are not very sure is it washing out or not, literature have told you that you can pick up 2 centimeter. In my teaching files, I've got cases of 7 millimeter, which we have picked up
Yes.
because of this, and they have been confirmed. It is common sense. How? Because in that 7 millimeter of nodule, there are no hepatocytes, and it gives you the answer. So the point is that I was just answering your question, but for your 2B world, forget about it. Nobody is going to ask you.
Thank you,
Okay.
Dr. Khan. Yes.
2B is smaller, simpler than this. Okay. Now, candidate
2, yeah.
2. My God, we have lost too much time, actually. This was a bit longish, isn't it?
Because because the 2 cases are in infantile cortical and this lesion. So
yeah, both were, yeah. So we
both
will
was
now speed up. We will
yeah.
speed up.
Okay,
And
yeah.
there is another case also there where I will do a bit of teaching, but I want to speed up now. Okay.
Yeah.
So this patient has got upper abdomen pain and has got upper abdomen pain and has got hypoglycemic attacks. Over to you.
Okay. I'm presented with axial CT scan on the portovenous phase. I'm trying to request. Yeah, I'm requesting. Sorry again. Yeah.
Yeah.
CT scan of the abdomen.
Just look at the pancreas, please.
Yes, yes. In the portovenous phase. Can you adjust the window again, please, Dr. Khan?
Yeah, I will make it for you. Here you are.
Thank you. Yeah. So in the portovenous phase, I'm checking the pancreas. This is the uncinate process, the head, the tail, and the body. There is nothing significantly enhanced, although I will see it on the arterial phase. It's much better delineated if there is abnormal, tiny, small.
I've given you the arterial phase. Now see it.
Okay. Sorry. Yeah, I can see there is a tiny enhanced lesion on the tail of the pancreas. It's a very small lesion, about less than 1 centimeter. It's intensely enhanced.
What is your conclusion?
So this is an islet cell tumor, most likely in the setting of hypoglycemia. This could represent an insulinoma. It's an islet cell tumor, neuroendocrine
What will you advise?
So this patient also might benefit from an octreotide scan for further confirmation of this lesion. Technetium indium 111 octreotide scan for further delineation of the lesion, and if there is any other metastatic lesion within the liver or not seen on the CT.
Then what are you going to advise?
So this patient will be referred to, if he had symptoms, it will be referred, be discussed on the MDT meetings for a possible surgical resection of this mass.
Can this be a malignant lesion?
Yes, it can. It can be a malignant
lesion. What are the chances of malignancy?
Insulinoma is less likely to be malignant, but gastrinoma is more malignant. So,
what are the chances of an insulinoma to be malignant?
Insulinoma, I think it's from 10 to 20% only.
Okay, thank you.
Yeah.
Pancreatic tumors can be divided into, so by the way, the differential, so the diagnosis was that it was a neuroendocrine tumor, insulinoma. Nobody can say it's an insulinoma, but I gave you the history. Otherwise, I would have just refrained from giving you the history. This is the tumors can be solid and cystic, solid pancreatic carcinoma, and pancreatic neuroendocrine tumors. This is from your book, Solid Pancreatic Lesions. Look at this, hypovascular. Now, pancreatic carcinoma is hypovascular, and that is why it is hypodense as compared to the parenchyma. And then there are hypervascular tumors. And neuroendocrine tumors are extremely important for your exam, extremely important. And they can be hyperfunctioning and they can be non-functioning. Please remember, all of them can be malignant. But the rate of malignancy in insulinoma is less than anything else. It is 10% only. But other than that, look at this one, 100% malignant, more than 90% malignant. So you ideally, in an ideal world, you advise to get rid of them. And these days, even your answer that I will do a nuclear scan is fine, but people don't do a nuclear scan in the context of it. They just, get rid of it. But of course, your answer is correct. If you want to elaborate that, I want to rule out this. You have to remember this. This is extremely important for your exam. In the case which I showed you, I actually told you it was a leading history, which at times the examiners are not going to that much. It was a satisfaction of search type of a case, if I give you in the exam. And then I will give you a hint, look at the pancreas, that kind of a thing. But you have to, the eye see what the mind knows. And what is written here, you must remember. Gastrinomas, multiple in 60. What is it? Multiple in 60%. So you should look, once you pick up one lesion, look for another lesion. And look for gastrinoma triangle. They can be outside the pancreas, they can be outside the duodenum in this triangle. And then look for other, look at this, extrapancreatic 50%. And there are, men 1 and men 2. Remember these. I don't want to go into this for your long cases also. Remember, they can show you cases from men 1, men 2, a combination of all of these. Please revise these, men 1 and men 2. Pancreatic neuroendocrine tumor, two things which you have to remember, which is slightly different than a pancreatic carcinoma, that they will enhance arterial phase. You see this? And calcification is more common in pancreatic neuroendocrine tumor. This diagram should be etched in your memory. It's an exam diagram. Remember this. The eye see what the mind knows. Remember gastrinomas. They can occur within the pancreas. They can occur in the intramural, in the duodenum. They can occur outside the duodenum. If you don't know this, a gastrinoma sitting here, you will not pick it up. And a gastrinoma sitting here, you will not pick it up. So with gastrinoma, for example, this is an arterially enhancing tumor, which is actually projecting inside the duodenum. It shows a bit of low, a washout type of a thing on venous phase. Washout, don't worry about it because it enhances here. With that, rugal fold. If the rugal fold are thickened, look for, that is what we call Zollinger-Ellison syndrome. And with that, I think I've shown you quite a few cases in previous sessions, gastric fold thickening, and in Zollinger-Ellison syndrome due to a gastrinoma causing excess. So must remember this. Now, going back to the case, so I warn you that in a classical scenario, the examiner is not going to be so helpful. Initially, the examiner is going to see your protocol, then might give you a hint. Look at the pancreas, for example. Even on this venous phase, this is a venous phase. Actually, the lesion can be seen here. And as soon as you see it, you ask for an arterial, and on arterial, it is better seen. And then as soon as you see it, I want to just rule out anything, any multiple lesions, and I'm looking for that. Then go for metastasis. In the exam case, there might be metastasis. I warn you, because these can be malignant and there might be metastasis in the liver. Okay, next, please. Over to you.
I'm presented with a frontal chest radiograph of skeletally mature female patient. I can see there is abnormal enlargement of the heart. There is cardiomegaly. Checking the lungs. There is no. There is subtle subtle opacity seen projecting at the right lower zone. It's well defined, and there is no underlying grip destruction. I'm checking the bones, the clavicles and the shoulders. The left humerus also, there are abnormal medial cortical erosion, and there is also abnormal trabecular pattern involving the left humeral head with abnormal contour of the glenoid as well. I cannot see any soft tissue masses surrounding the shoulder joint, and the acromioclavicular joints looks normal. On the other side, there is no abnormal findings on the right humerus. So this could represent an inflammatory process or aggressive lesion involving the left upper humerus.
What is happening here?
I would like to magnify the image a little bit and also dedicate to check this.
Can you see my mouse, please?
Yes, I can see it, but I can magnify it a little bit. There is a soft tissue calcification or this presented periosteal reaction, something here. I would like to do, yeah. I think this is soft tissue or part of the elbow. I'm not quite sure, but I would like to do an X-ray for a full humerus to detect to see the abnormality much clearer.
Look at the AC joint. Look at the AC joint.
The AC joint on the left and the bilateral AC joints are slightly widened. There's some resorption also of the lateral aspect of the clavicle. So
your conclusion.
So this in the finding combined together with soft tissue calcification and the erosion of the lateral ends of the clavicles, slight cardiomegaly, and this could represent a systemic disease like secondary hyperparathyroidism. I would like to check if this patient has a chronic renal failure or under dialysis.
Okay.
Also
Thank you.
Thank you.
Candidate 3, be ready now. Okay, so this was a case of renal osteodystrophy, secondary hyperparathyroidism. I covered it in great detail in, I think, last session or last to last, so I'm not going to go into that. One of the favorites in the exam, hyperparathyroidism and renal osteodystrophy, and all kinds of films can come. Now, erosion or absence of outer end of clavicle. Parathyroid, typically bilateral symmetrical resorption of other sides, blah, blah. Insertion, coracoclavicle ligament insertion, sternocleidomastoid, greater and lesser tuberosity of humerus. Greater and lesser tuberosity of humerus means the supraspinatus tendon, the rotator cuff, right? Now, this is renal osteodystrophy. The radiology of renal osteodystrophy is, stigmata of osteomalacia and rickets, and then secondary hyperparathyroidism, and with that there can be increased bone density. So I'm not going to go into that, but I just want you to remember that in hyperparathyroidism there can be bone resorption everywhere. Subperiosteal bone resorption, there can be intracortical bone resorption, and ostial trabecular bone resorption, subchondral, subligamentous, subtendinous. Where the tendons are involved, are attached, there can be resorption there. This is a case where you can see resorption of the distal end of the clavicle bilaterally. Now, with that background, let's go back to our case. And our case was, if you see here, it's a story case. It tells you a story. Oh, just 1 second. Actually, I forgot to show you for your memory one case which candidate 3, candidate 2.
Yes, sir.
Oh, you see this thing?
Yeah. This is the same case?
No. It's a different case. Just
yeah.
for your, this is the story, right?
Yes.
If you see here, this is a totally different case. There was a fistula here, which is no more being used, but you can see that oligocronone, there is resorption here, and this is because of the triceps insertion here. This thing was visible on our case. It was at the edge of the film, and the eye see what the mind knows type of a hypothesis. So you see this? It's a very harsh call, but once you have picked up, then you can see what is happening. Basically, what is happening is that you see from here to here, clavicle there is a gap. It is eroded. Now, from here to here, there is a gap. It is eroded. With that, you can see this erosion where greater tuberosity. And with that, once the examiner tells you something is there, and then this is what it was. So this was a case of secondary hyperparathyroidism. It was a renal osteodystrophy, and there are metaphyseal fractures also sitting there. Cupping of the anterior end of the clavicle, there can be metaphyseal fractures there. Now, okay, good, well done, candidate 2.
Thank you, Dr. Khan. Thank you.
Okay, candidate 3, are you with us?
Yes, doctor.
Okay, over to you. This patient is a 83-year-old, headache, tinnitus, loss of balance.
Okay, can I request a remote control?
Yeah. With you.
Okay, doctor. I'm presented by CT brain of a patient, 83 year, has headache, tinnitus. I'm scrolling, then I'll start to comment in the images. This is the non-contrast CT brain.
Yeah.
At which I can see that there is a soft tissue destructive lesion, which I can see here at the left petrous apex. I think it's in the area of the jugular foramen, which I need to confirm in the bone window further. Yes, here in the bone window, I can see there is an expansile destructive lesion associated with bone erosions and scalloping. It's epicentered in the jugular. It's epicenter in the jugular fossa.
You're not scrolling.
Yeah.
Let me do it for you. Yeah, you can do it.
Yeah. Now I'm scrolling, doctor. Yes.
Let
Here
me make this window better. Just 1 second.
Okay, doctor.
Just 1 second.
Sure. Yes.
Over to you.
Yes, this is the bone window. I
Yeah.
can see here there is an erosions of the petrous temporal bone and erosions affecting also the jugular foramen. I'm trying to see if this lesion extending into the middle ear or not. I assume that there is some extension also to the middle ear. My differential for this lesion, maybe it's a glomus jugulotympanic tumor. Other differential may be a schwannoma, which is less likely because schwannoma will not cause that much destruction. Other differential diagnosis may be skull base metastasis. I need to see this case further in the contrast study, better with MRI, for further assessment of this lesion and to see the relation of the lesion to the internal carotid artery and the jugular veins, and see the vascularity of this lesion.
Show me if the lesion is going into the middle ear.
Sure, doctor. Yes. Here I can see that the middle ear cavity is opacified. The ossicles
middle ear cavity is opacified. Tell me the names of the parts of the middle ear.
Yes, okay, doctor. Here now the ossicles are intact. This is here the mastoid air cells, here the adductus ad antrum, and here I can see the middle ear cleft. I can see the ossicles here are not eroded and they are intact. Now I'm going down. This is the above here. This is the attic space, and further down, I'm the mesotympanum. I can see filling the filling of the cavity, and here I can see that the lesion is eroding into the middle ear cavity, into the hypotympanum. I need to verify this better in the coronal images if it's available.
Is the cochlea intact?
Yes, I can see. This is here. This is the cochlea.
Just 1 second. 1 second.
Yeah.
Don't move the mouse.
Sure.
Yeah.
Yes. Now here I'm focusing in the cochlea. Yes. Yes. Yes, this is the cochlea, the turns of the cochlea. I think there is a fistula with the cochlea here.
Where is it? Point it out.
This area?
Okay. Well done. We stop here.
Okay, doctor.
Glomus jugulotympanicum. Just a bit of anatomy. Now, this is the base of the skull and the temporal bone. Here is the temporal bone. This is the occipital bone. Now, here is the jugular foramen, which is a foramen in between the temporal bone and the occipital bone. So, the jugular foramen, if you see here on this diagram, has got two portions. You don't have to remember it, but because on radiology you will see it, you should understand that this is the shape. And this is known as pars vascularis, pars nervosa, pars vascularis. The ninth nerve passes through it. The jugular vein passes through it, as well as the other nerves, the 10th, 11th nerve. So, then another thing which you have to remember, think of the jugular foramen as sort of the floor or the basement. Basement is a better concept to remember of the middle ear. This is a coronal sequence. This is the middle ear cavity. This is the middle ear cavity. Now, this is the basement. And this basement, the jugular vein is here. Now, and sometimes there is a concept of a high riding jugular where it will come here, and there is another concept of dehiscent jugular where it will project into the middle ear. And in the middle ear, this portion is known as mesotympanum. This is the hypotympanum. This is the epitympanum. Now, so this is the mesotympanum. This is the hypotympanum. I'm not going into the details of, maybe I'll show you a case of cholesteatoma, etc. Maybe next time, and then I'll teach you more detail anatomy once again. But today, it's a overview of anatomy. Now, so this is the middle ear. Just remember this, that this is the middle ear, ossicles malleus, incus, stapes. This is the inner ear, lateral semicircular canal, superior semicircular canal, vestibule, and this is cochlea. This is the stapes. So this thing can go in from here, this tumor. This tumor can go in. Now, this is middle ear lesions. One of the tumor is glomus tympanicum. The concept of glomus tumors are that these can occur anywhere from the arch of aorta till middle ear, because there are chemoreceptor cells there, and it's a very vascular tumor which can arise from. The name changes according to the location. Please remember that. The name changes according to the location. So glomus tympanicum can be sitting inside, sorry, I think the slide is not here, but glomus tympanicum can be sitting inside the middle ear. It arises from the middle ear over the cochlear promontory. Glomus jugulare, when the tumor is sitting on the jugular foramen, we call it glomus jugulare. But the glomus jugulare can erode into the middle ear cavity, then we call it glomus jugulotympanicum. So remember this word, glomus jugulotympanicum. So it has gone from the jugular foramen into the middle ear cavity. And if it stays just around the jugular foramen, we will call it glomus jugulare. And please remember the same tumor when it is at the bifurcation, of the common carotid. Within the carotid sheath, we call it a carotid body tumor. Now, this is from the glomus jugulare. And look at this one. This diagram tells you everything. Glomus jugulotympanicum, it has gone in. Now, key point to remember, the top differential diagnosis in glomus jugular foramen tumor are glomus tumors as well as a schwannoma, because the nerves are also passing through. Key point to remember is that the glomus tumors, they cause permeative bony destruction. Remember this. This is a key point to remember. One point to remember is that they cause permeative bony destruction. Look at this. You can imagine how because it's very vascular, it will cause permeative bony destruction. Look at this picture, and this picture is an exam picture where you can see this look at the outline, and it is permeative bony destruction. A schwannoma will cause expansion. It will not cause permeative bony destruction. This is permeative bony destruction. On MR, one of the exam thing which you have to remember is salt and pepper sign. In salt and pepper sign, what happens is this sign is on a T1 weighted pre-contrast. Remember this, pre-contrast T1 weighted. Salt and pepper sign. Salt is because there are high velocity vessels, they will appear as low signal. Pepper is microhemorrhagic foci, which are high in signal. Salt and pepper sign on a T1 weighted sequence. So these two signs you have to remember for your 2B. Permeative bony destruction on CT, salt and pepper sign on T1. Now, this is jugular foramen lesions. Look at this picture, and this picture versus this picture also tells you. Schwannomas or, anywhere they cause expansion of the bone. They do not cause destruction, rib notching and scalloping and all those things. So this is a case of a schwannoma, which the tumor is here and it goes into the carotid sheath. And this is how it looks like on this diagram. And this is the type of picture which it will cause. It will cause expansion. Look at the edge. There is no permeative bony destruction. So let's go back to our case. And now, this patient, by the way, had renal failure, also had a pacemaker, and the patient was okay except for these symptoms, refused any other imaging. But even here, we can see what it is. In these kinds of cases, the VIVA will be all on anatomy. So you remember this. Even if your diagnosis is absolutely correct, the VIVA is going to be anatomy. So let me go through this. Now, candidate did very well, where picked up this lesion here. Even the soft tissue component was seen and going into, without contrast, going into the carotid sheath here. Now, on bone window, what we can see is that here you are. Let me show you normal cochlea and anatomy. So this is, just concentrate on this side. And jugular foramen can be on one side, it can be more prominent than the other because the transverse sinus might be hypoplastic. So this is the jugular foramen. As we come up superiorly, this is the carotid canal. All of these things will be asked in the exam. This is the carotid canal. The carotid canal artery is going anteriorly. And let me slightly change the window. Now, look at this. This flower is cochlea, right? And over the cochlea, there is a bone here where I'm pointing out. And this thing is the internal auditory canal. And this thing is the vestibule. And then these are the lateral semicircular canal. This is the lateral semicircular canal. We are at the epitympanum. This is the head of the malleus, and this is the incus. So this is the adductus ad antrum. This is the epitympanum, and this is the mastoid air cells. And then we go down here. This is the cochlea, and of course, the middle ear is here. This is the eustachian tube, which is going anteriorly. But then we go inferiorly, and we can see the what we call the jugular foramen. And this is a coronal. And we can see this. This is the lateral semicircular canal. This is the cochlea. This is the cochlea. This is the middle ear cavity. And here is the jugular foramen. Now, coming back to our case, in this case, what is happening? You can see this. This is the carotid space, carotid sheath. There is a huge tumor. Even on bone window, you can see this. And look at the edge. Look at the permeative bony destruction. That's a key find. And this is the carotid canal. One can argue that maybe portion of it is eroded here. So this is where the internal carotid artery is. As we go slightly superiorly, we can see that the middle ear cavity, this is the external auditory canal. It is all filled up. This is the tumor. And you can actually see this connection between the cochlea and the middle ear cavity. And that was a key finding. This patient had a lot of dizziness and tinnitus, loss of balance. So the cochlea, there is fistulization of the cochlea. And by the way, one can argue that there might be some fistulization. This is the lateral semicircular canal, and you can see this defect here. So the lateral semicircular canal fistulization is also there. And this is the malleus, etc. So this is what it is. In any case, I think next time I'll show you a few temporal bone cases, and we will revise the anatomy, the fine touch of it, and consolidate the anatomy next time. Okay, well done, candidate. You did very well. And this is a venogram type of study, normal, just to tell you what happens regarding the vessels. You see, this is the carotid canal where the carotid artery is. This is the transverse sinus, the sigmoid sinus. It goes down. So this is the jugular foramen. And do you see this is the carotid artery? And then the carotid artery, the vertical part, it goes into this carotid canal, goes anteriorly. And the jugular foramen is slightly more inferiorly. Okay, next, please. Candidate 3.
Yes, doctor.
Over to you. What do you think?
I'm presented by abdominal radiograph of an adult patient, at which I can see that there is dilated small bowel loops at the center of the abdomen.
Conclusion.
This is a case of small bowel obstruction. I'm trying to check if there is any free intraperitoneal air. I cannot see the diaphragmatic crura to judge if there is an air under the diaphragm. I'm checking for if there is a pneumobilia which is I'm not able to see. I'm trying to see if there is any signs of free intraperitoneal air. I cannot see in these images. I'm trying to search if there is any cause of this obstruction. Like,
what will you like to do?
I like to proceed. This is a case of emergency. Immediately, I will inform the referring physician, refer to surgery, and do CT to check for the cause and the complications.
Okay, over to you.
Okay, doctor, I requested remote control. So this is a CT scan of the abdomen and pelvis. I'm scrolling through the case, then I'll start to comment. In this CT scan, I can see there is a small bowel loops dilatation. I'm trying to search for a transition zone. From the first instance, I couldn't see the transition zone. So I will trace the bowel loops. I will trace the bowel loops to find out the transition zone. I'll start first from the rectum till the ileocecal junction, then I will come up.
Look at the small bowel, please.
Sure, doctor. So I'll start to trace from the stomach. Here is the stomach. Can see the stomach, the duodenum. Now I can see the jejunal loops. I need to see the ileocecal junction. Here is the ileocecal junction. It looks normal. I look for the superior mesenteric artery and vein
Any
relation.
other sequence you want to see?
I need to see also the lung window to check if there is a free intraperitoneal
There
air.
is no air. Anything else you want to see? Any other
Yes,
sequence?
I need to see the relation of the superior mesenteric artery and vein to rule out midgut malrotation.
No, any other sequence you want to see?
Coronal, doctor, I need to see.
Right, here you are. Just 1 second. Don't move. Yeah, over to you.
Yes, here in the coronal, I can see that there is.
Just look at the small bubble.
Yes, doctor. In this sequence, I can see there is a cluster of the small bowel loops centered at the mid
Please
of
move
the.
your mouse. Please move your mouse. Don't be
Yes.
static right now.
Okay. I
You
will
move your mouse.
request again, I think.
Yeah, it's moving.
Yeah, it's working. Yes. I need to see the lead point. Here, doctor, I can see that there's the bowel loops are making like a closed loop at here.
Point it out to me.
Okay, doctor.
So
Here,
what is your conclusion?
this is a case of a small bowel obstruction. Mostly it's due to a closed loop obstruction. I need only to see the lead points and
Where is the transition point?
yes, doctor. Here I think there is transition point,
Okay.
and I need to see the other lead point. I think here also, doctor, in this area. I couldn't see signs of ischemia. I can see the bowel wall enhancement is rather symmetrical. There is no areas of hypoenhancement. There is no appreciable smudging of the mesentery to suggest bowel ischemia.
So conclusion.
This is a case of small bowel obstruction due to closed loop, likely due to closed loop obstruction.
Right. Okay. Because of time factor, I will quickly go through it. This is a case of, so of course, this was well done. One thing I want to highlight to you is that you mentioned the word that there is no free gas under the diaphragm, or you mentioned that the diaphragm are not visible. Please remember, on a supine film, the signs of pneumoperitoneum are different. Under the diaphragm is erect, and that will be on a chest PA component of a film. So we don't do, in UK, we don't do any erect films. And in erect films, of course, there will be levels. Now, this case, of course, is why I have selected this is, the fine touch of the concept of what we call, I use this analogy of this thing. This is Crohn's disease with small bowel obstruction, skip lesions were there. This analogy. Consider stomach and the rectum or renal canal here, and you have to go all the way till here, or vice versa, or up and down, stomach to rectum. And the point is that is what this case is about. Now, if you go here, trace everything on an axial, and on in small bowel, as we have highlighted before also, coronal is the best sequence. Even here, for example, once you pick up a dilated loop, try to trace it. And as I am tracing it here, one can see that there is as if a transition point, and this becomes, and then it becomes slightly better. Now, similarly, there are other transition points or other. Look at this one. Look at this one. I'm picking them up randomly. Look at this one. There is something wrong here, and then look at this loop here. look at this transition point here. Now, this is the ileocecal junction, maybe a bit of thickening here, not very significant. So if you go to coronal and look at these loops, and whenever you, in your day-to-day practice also, whenever you want to highlight a loop, you can actually uh, actually change the window and you can see it like this. And then try to see what is happening. Try to trace each and every loop which is dilated. Go up and down. Ultimately, you will, here you are. You see this segment here. It is inflamed. And then this loop, it is slightly thickened. It's a chronic type of a condition, but acute over chronic type of a condition, not very, very acute. Then look at this loop. This loop is normal. And then comes this abnormal loop. This is another abnormal loop. So the key thing is that whenever you see a dilated loop, try up and down, and ultimately you will see the afferent loop. Even here, this one was dilated. As I'm tracing it, you can ultimately reach a loop which is slightly, here you are. Look at this one. So these are multiple skip lesions. Now, on this coronal, you can see this is the cecum, ileocecal junction, quite fibrosed because it should have been thicker than this. And then you can see a bit of mucosal thickening in the terminal ileum here. So this is skip lesions, and that is what this was about. Skip lesions is quite pathognomic for Crohn's disease. And then look at the mesenteric lymph nodes. These are also better seen on the corona. This is on the corona. Okay, candidate 3.
Yes, doctor.
Spot case. Considering the time of the day, this is either you know it or you don't know it. You will take 1 minute to finish this case.
Yes, this is a histogram. I can see the hysterosalpingogram. I can see there is the fallopian tubes are markedly dilated.
So you feel that this is a fallopian tube?
No. It's not the usual appearance. Yes.
Then
I feel that there is some fistula here in this exam. The veins, doctor?
say again.
Is it these veins?
Veins. So what comes to your mind? What do you call it? How can you explain
Extravasation?
Extravenous extravasation. Well done. Well done. Good. So this is a case of, and by the way, this is an exam case. So remember, whatever I show you, these are exam cases. So venous extravasation on HSG, this is what it was about. This is a normal HSG, and venous intravasation, this is from Radiopedia. It can happen unintended introduction of radiopaque contrast into the local venous system, excessive pressure. So the examiner is going to ask you this. There is a problem with the technique. Another question which is asked, when will you do this? And there can be some questions about the technique. And you have to remember it is done in the proliferative phase, 6 to 12, and you should be worried so that the patient, there is no chances of patient being pregnant. Otherwise, if you've got just an iota of, doubt, go for beta HCG. So this is also a VIVA question. It's a film which is an aunt mini, but if you have not seen it in your life, you will never pick it up. And once you have seen it once, you will never miss it. So basically what is happening, because of the high pressure from the endometrium, it has gone into the myometrial veins, and then it has gone into the pelvic veins. And it is, for a moment, if you do it under fluoroscopy, for a few minutes, it will stay there, then it will just vanish. So this is venous extravasation. Two things you have to remember: wrong phase and excessive pressure. Last case of the day. Just 1 second. How's the resolution for you? Okay?
It's okay, doctor.
Right. So because of the time factor, this case is an interesting one. What happened was that this patient has an intraparenchymal hemorrhage about 20 days ago, 3 weeks ago, and the patient has developed right-sided trigeminal neuralgia. Right-sided trigeminal neuralgia. So an MR was done. Now, because of time factor, let me go through the hemorrhage part of it, and then I will hand over the case. As far as the intraparenchymal hemorrhage is concerned, we can see that on a T1 weighted sequence, most of it is high signal. But if you go to the T2 weighted sequence, it will show you a rim. Here you are. This black rim is hemosiderin rim. So by definition, this becomes a chronic hemorrhage. Please remember this. So because of time factor, this part of it I will cover right now. Here, early subacute, late subacute, and chronic. More than 14 is chronic. And here what happens is that there is a hemosiderin rim which surrounds it. So by convention, what happens is that a hematoma is known by the oldest component. In a hematoma, if there is a component which is hemosiderin, you call it a chronic hematoma, though in the center of the lesion, there is high signal on T1, which is subacute component. With that thing in mind, I am not at all interested in the hemorrhage. This scan was done because the patient has developed right-sided trigeminal neuralgia. Over to you, please.
Okay, doctor. I request remote control. So this is a T1 weighted MR images. I'm scrolling through the images. Apart from the hemorrhage that was noted before, I can see that there is an areas of abnormal high signal intensity that I can see at the region of the right cavernous sinus and the right orbit, as well as
excuse me, the orbit part is technical because the fat saturation is not happened.
yeah.
So forget about the orbit, but what's happening in the cavernous sinus?
Yes, here I can see there is an area of an abnormal signal which is present in the right cavernous sinus, Also, I think it's here in the right suprasellar region. However, I can see the internal carotid artery is flow void signal is maintained.
What will you like to do next?
I like to see the signal, this signal changes in other sequences, like a gradient echo images,
Okay,
and
just a second. This is a gradient echo. Sorry, just 1 second. I am going to. This is a gradient echo. This was your hemorrhage, and it is nothing impressive as far as that is concerned. What else would you like to see?
uh, can we see the diffusion weighted images, Doctor?
Diffusion was also not helpful. This is the diffusion.
Mm.
This is the high B value,
Yeah.
and nothing important. Next, please.
Uh, I can see the signal changes in the T2 or
So T2, this is the T2.
yes, it's bright also in T2.
What else would you like to see?
The only remaining is the contrast study or cis study.
Contrast study.
Yeah. Yes. Yes. Here in the contrast, I can see there is a abnormal enhancement in the area of the suprasellar stern and the right cavernous sinus, which appears to be larger and sizable than the other side. Uh, the the flow void is maintained in the internal carotid artery. Uh, yes, here I can see there is a marked enhancement of the cavernous sinus of the sella.
What is your conclusion?
This patient has a history of hemorrhage. So I can see this is a basal
Hint, don't get confused about the hemorrhage.
lymphoma. This is a case of lymphoma. Something unrelated to the
Right.
organ.
Okay. Okay. That's it. Thank you.
Thank you, doctor.
This was a case of
Meningioma. Yeah.
meningioma with
Yeah.
now the hemorrhage part we have covered it. The anatomy is, the history was very right-sided trigeminal neuralgia. The patient just presented with this, and they thought that something is happening because it was left-sided. And they did this scan. Initially, only a CT was done, and this lesion was, of course, not picked up there. Now, the anatomy is Meckel's cave. This is where the Meckel's cave is. This is the fifth nerve, which goes into V1, V2, V3. V3 goes into foramen ovale, foramen rotundum, superior orbital fissure. And this is the cavernous sinus, and V1 and V2 passes through it. Now, this is another case of meningioma in which the key point is that in these cases, the questions will be about anatomy. And the concepts which I am telling you quickly, these will be asked. So if you see here on this T2 weighted sequence, you can see CSF here. This is another case, by the way. This patient presented with right-sided neural, this trigeminal neuralgia. CSF here, and this is now enhancing lesion here, which is sort of, you can imagine that the cavernous sinus is completely obliterated. This is cavernous sinus. This is CSF, which is in the correction, the Meckel's cave. So this is paracellar. In your book, there is a cavernous sinus or paracellar mass. This is an extremely important region for your exam. And I warn you, once the case will be shown to you, then the questions will be on anatomy. What is happening here? What is here? Show me this, show me that. Where is, MCA? Where is ICA? Where is... So these kinds of questions will be there. And here, in another case, this is the cavernous portion. And normally this is the cavernous portion. This is the cavernous portion. This is the of the internal carotid, I mean. This is the cavernous sinus. And then look for dural tails, etc. I am not going to go into this, the signs of invasion of cavernous sinus, which is slightly beyond to be word there. So now, so if you see here on this, this was a pre-contrast. So this is a pre-contrast, which maybe you should have asked before the post-contrast, or once the post-contrast was shown, maybe you should have asked that I will compare it with the pre-contrast, and you can see everything is enhancing. Now, if you go here, this is the cavernous portion of the internal carotid artery, cavernous portion, and there is enhancing tissue. You can see dural tail here, you can see dural tail here. And then as we go up, you can see dural tail here also. Portion of the lesion is extending into the suprasellar region. Now, key finding here, this is the Meckel's cave, and that Meckel's cave is obliterated. Of course, it's a big tumor, and portion of it is going into the suprasellar region, which I was showing you on axial. And this is the pituitary gland where I am, and the examiner can ask you if it is a macroadenoma, which can invade the cavernous sinus. No, it is not. It is sitting next to it. It is a paracellar. And the dural tail is a giveaway. Dural tail is a very important sign. And there can be dural tails right and left. Look at this dural tail. Look at that dural tail. So paracellar meningioma. Okay then, thank you very much.
Thank you, doctor.
I think next week somebody else is teaching, if I'm not wrong. But then whenever I will teach, I will do another Pot-Purri and maybe show you a few cases of temporal bone also.
Doctor, can I ask a question?
Madam.
Yes. Can I ask a question?
Yes. Quickly. I have to
okay.
I'm in a bit of a
I
hurry.
understand. How to differentiate between this meningioma and other chordoma and this
Chordoma.
things.
You are confusing here. Chordoma is clivus tumor. In head and neck, in base of skull, in neuroradiology, key thing is what is the epicenter of the lesion. And with epicenter of the lesion, the differential completely changes. Chordoma, by definition, happens in the midline. Anatomy is the key. It will be in the clivus, and it will be midline. A chordoma should be differentiated with a chondrosarcoma, which occurs from the suture in between the petrous bone and the sphenoid bone. And that's a totally different world. On the other hand, this is a paracellar region. It is in the cavernous sinus. In the cavernous sinus, there are many tumors which can happen. However, meningioma and pituitary macroadenoma are the key differential diagnosis. There are pituitary macroadenomas which invade the cavernous sinus. And this was a meningioma which was invading the cavernous sinus. It was going into the suprasellar. So there is a lot of it. I'll have to show you many tumors around it. But because your question was specific, how do you differentiate between this and chordoma? Chordoma cannot happen at this location. End of story. That is slightly inferior. That is, chordoma arises from specific types of cells, and they are present along the neural axis at the two ends, either the clivus or the sacrum. These are the two main locations of the chordoma. So I hope I have answered your question, or is there a follow-up question, madam?
There is another question in my first case, which show bone island. How I differentiate between this one and in chondroma, which I told it is the.
So enchondroma, the answer to your question is develop your eyes. That is the answer to your question. I don't have time to show you right now because the cartilaginous matrix has got calcification. Why do you see that cartilaginous matrix on a X-ray? Because the density is more than the bone. And that density, that thing will be in the shape of ring and arcs. This was not at all like this. It had bony trabeculae. This thing had bony trabeculae inside. Rings and arc calcification is totally different. And actually the density will be even more than this. So the answer to your question is, my answer is develop your eyes. You have to go back to the basics to be able to, if I had one time right now, maybe I would have shown you.